Dr. McKeown is the director at the Brain Research Center out at UBC, and he has been a very active speaker and helps us a lot at the Society, besides speaking in terms of assisting us when we've got clinical issues we need to get information about. He graduated summa cum laude in engineering physics from McMaster University in 1986, which makes him doubly valuable as a researcher. Got a different spin on things, and subsequently he earned his MD degree from the U of T in 1990. He's not only a professor of medicine, but also of electrical engineering, as well as being the director of the Pacific Parkinson's Research Center. And we're just thrilled to have him join us here again today. And as I mentioned in the plenary session, Dr. McKeown, we have our second person to receive Duodopa therapy, Ms. Chris Olson, at the front of the room. So thanks to you for that too. Please join me in welcoming Dr. McKeown.
So I was asked to talk about advanced symptoms of Parkinson's disease, and I was also told that people wanted take-home messages, so I modified it a little bit and called it the 10 rules of dealing with advanced Parkinson's disease. So these are things that, having been in the business a little while, these are the things that I see come up over and over and over again when dealing with Parkinson's disease, as people with Parkinson's disease try to get on with their lives as the disease progresses, and also try and navigate through the often complicated world of our healthcare system. And so these are some of the things that I have seen crop up, and to advise you on maybe the best way forward. I have to give some disclosures. I do receive grant support. I receive honoraria for giving lectures. One of the things that's probably important is that AbbVie, the makers of Duodopa, provides support for half of a nurse at UBC. Half time, yes. Okay, rule number one is understand what the concept of a therapeutic window is. Now, what is this? This is something that, unfortunately, even a lot of physicians are not familiar with. And that is, when you take any medicine, for example, levodopa, what happens if we were to plot how much medicine is in your body over time, what happens is it gets absorbed and the levels in your body go up, and then your body starts to chew it up or metabolize it, and so the levels drop. And so this is typically what you see if you take a pill of any drug, particularly levodopa. Now, all drugs have what are called a therapeutic window, which means the difference between how much you need to take to get any effect. So if you lick the tablet, nothing happens, right, because the dose is too low. If you take bucket loads, eventually you're going to get a level where you start to get unacceptable side effects. And the difference between how much is enough and how much is too much is what's called the therapeutic window. Early on in the disease, the therapeutic window is very large. And this means you can be sloppy with your medicine, you can take it a bit early, you can miss a dose. It doesn't make a huge difference. Unfortunately, as the disease progresses, this changes. And so you need more medicine to be on, and then if you take too much medicine, you can get side effects, often writhing movements, which are the dyskinesias that you are all familiar with. And as the disease progresses, this gets narrower and narrower. So at some point, some people have an extremely narrow therapeutic window. And what this means is that, unfortunately, some people oscillate between having too little and too much. And these are what we call people with brittle Parkinson's. The term comes from actually people with diabetes. And sometimes, and you know, with diabetes, their problem is they have to keep their blood sugar at just the right level, not too low and not too high. And there are people who are brittle diabetics that no matter what you do, they either seem to have too low blood sugar or too high blood sugar. And unfortunately, with advanced disease, there are some people with Parkinson's who either have too little medicine or too much medicine. And this is why, as the disease progresses, you can no longer be sloppy about taking your medicine. early or late, because if you do, then you're going to get out of this window and you're either going to be dyskinetic or you're going to be wearing off and feeling very uncomfortable. And so the challenge is to try and keep you in this narrow window. Just as an aside, this reminds me to tell people that it's very important that you take your medicines consistently and on time. Not only is it a good habit to get into, but when you go visit your doctor, and if your doctor really thinks you're taking the medicine at noon, but you're actually taking it at 1 p.m., then the decision or the advice that you get from your doctor is going to be incorrect because they're going on wrong assumptions. As I said, the other problem is even a lot of physicians are not aware of this. So one thing that's a bit unfortunate is that the healthcare system is not tooled up to give medication in a timely fashion. So if you're in the hospital, it doesn't really matter if you get your blood pressure medicine half an hour late or your high cholesterol medicine if that's an hour early. It's not a big deal. But if you have advanced Parkinson's and you get your levodopa an hour late or an hour early, it can be a huge deal. And this is very problematic when people get on a place in the hospital where they're less familiar with Parkinson's. So for example, if you unfortunately break your arm and you're on the orthopedic floor, the people there may be less familiar with advanced Parkinson's and they don't know about this, that people have to have their medicines frequently and on time. So when we see people in the clinic, what we're trying to do is trying to keep you in this narrow window. And there's all sorts of tricks that we play. You can take smaller doses more frequently. We can change how fast the medicine is chewed up in the body. There's a medicine called entacapone, for example, that slows how quickly your body metabolizes the medicine. We can consider other medicines that also work on the dopamine system, like dopamine agonists, a medicine called rasagiline, and so on. So we do all these little tricks to try and keep people in this kind of sweet spot so they don't get too much or too little. Unfortunately, for some people, even that is not enough. And these are these people with brittle Parkinson's, and I'll talk a little bit more about what we do when none of these things seem to be working. So rule number 2 is if you have something funny and your doctor can't figure it out, always wonder if it's your medicine wearing off. Now, some things are going to be obvious. For example, if you have severe chest pain, you should always make sure that they rule out that it's a heart attack. But what I'm saying is once they've ruled that out and your doctor says we've done all the standard tests and we still don't know what it is, there are so many unusual symptoms that can present when the medicine's wearing off. Now, I don't expect you to read all this, but this is just to give you a feeling of all the different symptoms that different people have described as their medicine has worn off. Everything from pain to psychiatric changes, to changes in blood pressure, to changes in their pupils and everything. So, I've lost count of the number of times where I've seen people with some funny thing. They've been to their doctor's done all the tests to rule out the standard things, and in the end, what it turned out to be was that their medicine was wearing off. So anytime you have something funny and your doctor's ruled out the obvious cause, always wonder whether or not it could be the medicine wearing off. Rule number 3. Now, what happens when we decide, how do we decide what treatment to give someone? There's many potential treatments that are available, and when we see someone, you may say, well, what's the thought process behind deciding what medication or what surgical treatment to go through? And really, all it boils down to is we weigh the risks and the benefits of all potential treatments. A lot of people will think about the risks of a potential treatment. In other words, what are the side effects if I take this medicine? What a lot of people don't think about is what are the risks if I don't take this medicine? And so sometimes you have to weigh the pros and cons of everything, and we try and minimize the risk to people and maximize their benefit, and that's how these decisions are made. So let's think about what about, as I said, I mentioned someone before with brittle Parkinson's. If we've tried all the things that we can do with the medications and people still are not doing well, what other options are available to us? Well, one thing is deep brain stimulation or surgery. And another option, which has now recently been improved in BC, is Duodopa. Now, technically, I think there's some rule that says I'm supposed to say levodopa, carbidopa, and intestinal gel, but I'm sorry, I'm just going to say Duodopa because it's a little bit of a mouthful, but I'm sorry, UBC. So deep brain stimulation. So again, what are the risks? What are the benefits? Well, the benefits are pretty impressive. You know, there's no doubt about it. If you have brittle Parkinson's and you go through the surgery and it's successful, people do really well. Now, one thing to remember, though, is you never do better than when you feel at your best on medicine. Now, what the surgery does is it prevents these peaks and these valleys. But when if you're throughout the day having many wearing off and many excessive dyskinesias, there may be a couple of sometime during the day where you are just right. That's how the surgery is going to make you feel. You're not going to feel better than that. That's what the goal of the surgery is to keep you in that sweet spot throughout most of the day. So that's the benefit. And it is this it can be a real game changer for people. But like all things, you know, it's not 100% good. There are risks, and the risks are small, but they're not zero. So what are some of the risks? Well, I think this is excessively pessimistic because unlike medicines where, you know, the medicine that we give will be the same medicine as a doctor elsewhere would give, but surgery requires a little bit of the skill, or a lot of based on the skill of the surgeon. Now, we're very fortunate that we have Dr. Honey's an excellent surgeon, so I think some of these numbers here are a little bit pessimistic, but if you read the literature, they'll say there'll be some bleeding inside your head in 2 to 4% of cases. You know, there are lots of things that happen when you have any major operation. You know, you can get infections in your lungs, you can get infections in your skin, you can get blood clots. You know, so all of these, I would say, are usually easily dealt with. I mean, but it's not uncommon to see that after any major operation, like, for example, a hip replacement. But even though, let's say, you know, you get through all this, no bleeding during the operation, and you're a little bit confused, but now you're back, now you're better, there are some people that see that they have ongoing problems with their speech, or problems with their thinking, or they may become a little bit more impulsive. And this results in about 6% of people who get DBS of wanting it stopped. So that gives you a good idea of kind of the risks. So the benefits are certainly there, but the risks are there. So if someone comes to me and says, Doc, I heard on Oprah that DBS is really good for you. And if they're, you know, doing very well on medication without wearing off and without dyskinesias, then I would say, you know, your benefit is not going to be any better, and then you're going to expose yourself to all this risk. So when you weigh the risks and benefits, it doesn't make sense to go ahead with a surgery. On the other hand, if someone says, Doctor, I've got a terrible situation where I'm very brittle and I'm getting dyskinesias all day, or I'm wearing off and, you know, my life has just been turned upside down by this disease, then you would say, well, maybe it's worth the slight risk of going through the surgery, because once you go through with it, you know, you may do extremely well. So again, it's weighing the risks and weighing the benefits, and that's how we make the decision. Now, the only problem is sometimes Google won't necessarily give you the risks and benefits in an accurate fashion. But that's really what we are doing as physicians when we see people, is we're thinking in the back of our mind, what's the risk for this person and what are the potential benefits? And weighing that, does it make sense? Now, so that's what I said here, is that you basically weighing the risks and benefits. Now, there are some people, when you weigh the risks and benefits, that make them particularly risky for having the surgery, and these are people we would not recommend. So if someone has early or severe memory problems, it wouldn't make sense to go through their surgery because their memory problems may get worse. So you don't want someone who's doing fairly well, they have the surgery, and then now their cognition is much worse. That wouldn't make sense. People who have a lot of problems with their thinking, either hallucinations or thinking about things that are not true, this can be made worse by the DBS. So it would not make sense to go through with that. There is this rare condition it's got a big long name. It's called dopamine dysregulation syndrome. And what it is these are people who just like to take more and more levodopa. There's some people who just have to consume more and more, and it's very much like a levodopa addiction. And we know that those people do not do well with surgery. Same with people who are very impulsive, people who are, for example, like to gamble excessively and so on, or people who may have severe depression or have even thought about harming themselves. These people would not necessarily be good candidates for surgery because the risk would be so much higher. Even though they could get benefit, the risk would be high. Okay, now what about Duodopa? So I'm going to spend a little bit more time on this because I think people know a bit more about the DBS because they've heard about it. So this is a relatively new therapy. It's been available in Europe for decades, but it's only recently become available in Canada. And what this is it's basically liquefied levodopa that is infused via a pump through a tube that goes through the abdominal wall right into the gut. And what's good about this is that it means you get a constant infusion at a steady rate. And this has turned out to be very helpful and a real game changer for some people. Now, what is some of the benefits? Now, there have been a number of studies we won't bore you with, but this was one of the biggest ones where they had 350 people. About 3/4 completed the study. The off time decreased by 67%. The on time without dyskinesia increased by 63%. And the on time with dyskinesia decreased by 22.5%. So these are pretty amazing numbers for us in the field who deal with new therapies. This tells you that people who have had brittle Parkinson's, this has really made a huge change in their life, which is great. And the other thing is there was a large trial that was published in Lancet Neurology, which some would argue is kind of the premier neurology journal in the world in 2014. And this really provides very solid evidence that we can go to government and say there's strong evidence that this is a very effective therapy. Now, one thing that is kind of interesting is, remember I told you that when the medicine wears off, you can get sort of funny things that happen. You can have clouding in your thinking or you can have pain. So one of the things is if we were to continually infuse the medicine at a steady rate, we would expect the dyskinesias and the wearing off to get better. But one thing that pleasantly surprised us is there were a number of benefits on things that were more kind of a little bit harder to describe, like which we call quality of life things. So for example, people's sleep got a lot better. And there's different ways that there's different questionnaires that you can do that assess your quality of life. So one thing that was nice is this was kind of expected that if we continuously infuse things, a lot of the motor fluctuations will disappear. But what was a pleasant surprise is that a lot of these quality of life things improved as well. So these are the benefits. There's no doubt about it that for select people, this is very beneficial. But again, like all things, everything's got risks. So these are the risks. So this is, basically this is the number. So 8% ultimately withdrew because of complications. And this is kind of a busy slide, but this is basically saying there's two steps to this. One is you insert the tube in, which is a day operation. And then what we do is we send people home for a week or two and let that heal. And then they come into the clinic and then we titrate this so we get the personalized dose that's right for you. And what this is telling you is this is the risk of having an adverse effect after they insert this tube. And you can see all of it happens in the first week or two. So once you're out of the woods in the first week or two, then any of the risks are the same risks of just taking oral levodopa. So, but this does tell you that a lot of the issue is related to inserting this tube placement. Now again, I think this is excessively pessimistic because we're extremely fortunate that we have Dr. Gray at UBC, who's a gastric surgeon, an excellent gastric surgeon. So my suspicion would be is that our numbers will be much better over time than this kind of pooled aggregate that was done over many centers around Europe. So it does tell you that if you're, if you can get over the first week or two, you're likely out of the woods. And a lot of it is related to kind of the hardware of insertion of the tube. So who should not get Duodopa? Well, people who are unmotivated or non-compliant or have poor caregiver support. There is an issue where you have to work with the pump and control the pump, and if people are not willing or able or they don't have someone to assist them, then this gives us pause that it might be a recipe for disaster to set someone up with a pump that they're not willing or able to adjust by themselves or have strong support. So this is, again, another thing that would consider when we weigh the risks and benefits. This would increase the risk of it not being a good outcome for the individual. So the next rule, be vigilant about changes in mood and cognition. So this is something, again, that we see over and over again. We do know that that Parkinson's is because of an abnormality in the brain chemical dopamine. Well, there's another brain chemical, serotonin, which is very important for your mood. And so we see a lot of people who have decreased mood, and it's very treatable. Now, a lot of people say, well, of course people are depressed because they're less mobile than they used to be. But they've done studies where they've looked at other conditions that also affect mobility, for example, rheumatoid arthritis. And what they found for people who had equal levels of disability, the rate of depression was much, much higher in Parkinson's than it was in people who were equally disabled with rheumatoid arthritis. So it tells us it seems to be part of the disease itself. Now, there are a lot of people, and also this differs across cultures as well, who are very resistant to the thought that they might be depressed, and they might see it as some sort of failure or something like that. I would urge you not to think about that, because this is something that's treatable. We know it's an intrinsic part of the disease, and it can have a huge impact on your overall quality of life. I often tell people, if we can't get your mood under control, nothing else will fall into place. We can, try and titrate these other things till the cows come home, but if your mood is in your boots, you will not feel well, and we just can't get things sorted out. So I think it's very important that we are quite aggressive about treating this. We also look for cognitive changes. Cognitive changes are a little bit harder to deal with, but there are treatments out there that are quite useful, and so we should be screening for that and looking for that, and you should be mentioning that to your doctor if you think that that's happening to you. I often tell people the thing that's going to get them ultimately into trouble are swallowing and falling. So again, these are things that we should be looking at. So as Parkinson's disease advances, the big thing is you're going to become more frail. So 10 years ago, if you got a pneumonia or got the flu, you'd feel miserable for a couple of days. But as you become more frail, it's not just you're going to feel miserable, it's really going to throw you back. And so you're going to become more frail, and this is going to make you susceptible to things like falling. And so one thing you don't want to have happen is fall down and, heaven forbid, bang your head or break a hip, because then you're going to get into hospital and you might get infection. And, very often we see that this is, really sets people back. So a lot of people are very resistant to the idea of using walking aids. They don't want to use a cane or Nordic poles or a walker. But I would suggest that you want to be preemptive about this, because if you've fallen down and broken your hip or bashed your head, it's too late. Okay, so you want to be thinking of this before, not later. The other thing that's a big problem is swallowing. So just as your arms or legs can be clumsy, the muscles in the back of your throat can be clumsy as well. And swallowing is actually a very complicated movement. And what its goal is to make sure that water and food go down your food pipe and not accidentally down your windpipe. And one of the clues is that if you're coughing when you're eating or drinking, believe it or not, the hardest thing to swallow is a glass of water. And that's because it's very thin. So if you have something that's thick like applesauce, it tends to sort of stay in a clump. So if 90% was going to go down the right way and 10% down the bad way, because it stays as a clump, it all goes down the right way. But if you drink something thin like water, the 90% will go down the right way and 10% will go down the bad way. And that 10% is what's going to get you into trouble. So bacteria from your mouth can then go down into your lungs and cause pneumonia. So again, that's something that you want to avoid because that can really set you back. So if you're coughing when you're eating or drinking, you should mention that to your doctor. There are professionals called speech-language pathologists, and they assess swallowing, and they may take an x-ray of you swallowing a milkshake or something like that so they can see if anything is going down the wrong way. And there's various things that we can do about that. So this is something that you want to be vigilant about and think about. So aggressively deal with delusions and severe hallucinations. So this is the typo that I fixed, and then now we have to use the old one. But this should be, maybe I did fix it. Okay, so delusions are a strongly held fixed belief. And so what that means, it's kind of interesting that when people have some delusions, they're not random. They always seem to be the same things that crop up over and over again. A common one, for example, is infidelity of the spouse. People may think that their spouse is cheating on them. Another thing might be that people are out to harm them or people are stealing from them. Now, one has to be careful because maybe the housekeeper really is trying to steal from you, you know. So, but occasionally we will see people who have very fixed beliefs and it's apparent that it's not true. And this can have havoc on the family, as you can imagine, if someone's falsely accused of stealing or infidelity or whatever. And this can really cause a lot of pain and suffering, not only to the person with Parkinson's, but to those around them. And since this is usually quite easily dealt with medication, it's something you don't want to suffer in silence. You should bring it to the attention of your physicians. Normally when we see this, people are starting to have a little bit of memory problems. So the typical scenario is people with mild memory problems, and then they may get, for example, an infection in their bladder or something, and then their thinking goes off a bit. And one of the things that their thinking go off is they may start to, again, have these delusions where they think thoughts that are not real. Often they occur with hallucinations, so these are seeing things that aren't real. So sometimes people will, see a relative who's not there, or sometimes they may see intruders in the house, and that can be very upsetting to the patient and to people around them. As I said, if we hear about this, the first thing we do is rule out that there's not something else going on, like an infection that's kind of put the system out of whack. But assuming all that's been ruled out, it may just be the progression of the disease itself. And as I said, there are very good medicines that can selectively target this, and we can settle them down quite easily. Just to reiterate, this can really cause immense strain on caregivers and relatives, and so it's something that you don't want to be suffering with. As soon as you think that this may be going on, you should bring it to the attention of your physician. And just along that line, I think you need to be very vigilant about caregiver stress and burnout. So PD affects the whole family. It just doesn't affect the individual. It affects the people around them. And I think it's important to reach out with others. We strongly support the Parkinson's Society of BC because they're a wonderful organization because of these types of events. But they're there to help you and to advise you and maybe point you in the right direction. But I think it's very important that you reach out to people, because if you're a caregiver and you get burned out, it's not going to be in anyone's interest. It won't be in your best interest, and it won't be the best interest of your loved one if you can't handle things anymore. So I think it's important to reach out early. There are various options that can be available, and social work and perhaps some of the people of the Parkinson's Society of BC can advise you, where people can go into like an adult daycare for a few hours and give some respite care and give a bit of a break to caregivers. That can often be very helpful. Another thing I would say is advocate for yourself. Now, this is a bit of a touchy subject because this does not mean to go up and yell at the nurses, because I don't think that helps. But, my experience has been that almost all healthcare workers are doing their best to hold up an already overburdened system. So, like, I know our nurses will come in and they may have had 50 phone calls overnight on their phone because we deal with thousands of people. And as I said, they're doing their best. But the problem that I see is it's okay if you're in a specialized center where people are experts in Parkinson's, because we're familiar with many of the things. Where it becomes an issue is if you end up in part of the healthcare system that are less familiar with Parkinson's. And there are some things that can happen that could really set you back. And this is where I think you need to advocate. So, as I said, I don't want to pick on orthopedic surgeons, but if you break your leg and you're on the orthopedics floor, they probably haven't seen too many people with Parkinson's. And as I said, mentioned before, the healthcare system is not tooled up to give medicine usually in time-critical fashion. And so, especially pills, there are some injections like insulin that's given, but it's counterintuitive to most health professionals that people need to have their levodopa within 10 or 15 minutes. If you brought in 100 healthcare workers, probably 90% of them would say, no, that doesn't make sense. So you have to give it that in that narrow a time frame. Some medicines, though, that are, and I think you have a take-home bag, right, that's got the little card. So there's some medicines that we use almost in all types of medicine, so all types of healthcare. So, for example, on many, many different floors, surgical floors, respiratory floors, cardiology floors, if people are agitated for a number of reasons, they're given these medicines that are called neuroleptics or typical neuroleptics, and these are particularly bad for people with Parkinson's. So, as I said, you don't want to be on a floor, you're a little bit confused because you've just had an operation to fix your leg, and you're a little bit agitated, and then someone gives you this, that'll really send you back. The other big culprit that we see is medicines for nausea. So some of the anti-nausea medicines that are routinely used in surgery are very bad for you with Parkinson's because they essentially block dopamine, and so it will really throw you back. So this is where I think you have to sort of advocate for yourself a little bit. Rule 9, discuss palliative options. So this is actually just a growing area now in healthcare, I think, in the care of people with Parkinson's. It's championed largely by a colleague of mine, Dr. Janice Miyazaki from Edmonton, and it's saying that we have to be a little more supportive and have to think a little bit more about end-of-life care. And it's important that we discuss these things. These are some things that she has suggested your doctor should be doing. Use a holistic approach, include family members in the treatment plan, address non-traditional sources of suffering, and your priorities should be paramount. So let me give you an example. Remember I mentioned about swallowing being a big problem. So it is known that what happens if you can't swallow at all? No matter what you try and swallow, some of the food ends up going to your windpipe. What are your options? Well, there is an option to actually put a tube through the abdominal wall and you receive your nutrition that way. But to some people, eating and tasting their favorite foods is an essential part of their enjoyment of life and their quality of life. And so some people would say, okay, I know that I'm at slightly greater risk of getting a pneumonia if I continue eating, But it's very important to me because, food is part of my life's enjoyment. And so these are the sort of personal discussions that you need to have with your doctor. There's no right answer, there's no wrong answer. And these are the things that I think you need to discuss with your healthcare team so that your wishes are known and they can be best addressed. And finally, just remember that, of course, not everything that goes wrong is Parkinson's disease. And so there is a temptation when you have a prolonged illness to think that everything that can happen is going to be related to the Parkinson's. And we see this a lot where people phone into our nurses with things that are obviously not related to their Parkinson's. And unfortunately, as you get older, many things can happen besides Parkinson's. And so, sometimes you have to realize that if something else is not working, it may not necessarily be attributable to your Parkinson's disease. So remember, Parkinson's is generally a slowly progressive illness. So if Grandpa was great last week, but now he seems to be extremely confused within 1 week, that usually tells us that something else is going on. It's not just the Parkinson's. And so that's why we would often look for things like infections, or someone's changed their heart medicine, for example, so their brain isn't getting as much blood. There are all these things that can happen. People can get vascular events, be at risk for stroke or heart attack or so on. So any of these things can throw a wrench in the works, and it's going to upset the system. And that will mean that, you won't be doing as well, but it's not necessarily related to the Parkinson's. Now, the caveat to that is sometimes with an old car, as you know, sometimes when things start to go wrong, it doesn't, eventually, as something slowly progresses, it is possible that different things do go wrong. And it may appear to be relatively quickly, but then if you actually look back in retrospect, you would say, oh, well, actually, that person did have some memory problems 6 months ago, and it's not really just this past month that things have taken a turn for the worst. So, to summarize, these are what I suggested were the 10 top rules for dealing with advanced PD. Understand the concept of therapeutic window. This is this idea of brittle Parkinson's and how we have to maintain the dosage of the level in just the right amount. If something strange is going on, always wonder if it's the medicine wearing off. And if your doctor can't figure out what it is, it could be an unusual manifestation of wearing off. How we decide whether or not someone has advanced therapy like deep brain stimulation or Duodopa, we usually are thinking about it in a risk-benefit manner. Do the benefits outweigh the risks? Be vigilant about mood and cognition, because these are things that we can treat and will have a significant impact on your quality of life. Worry about swallowing and falling, because these are the things that often get people into big, big trouble, and they realize that it's too late, that they should have been using a walker or Nordic poles, for example. Aggressively deal with delusions, because this can have tremendous stress not only on the patient and upsetting people, but also those around you, which can lead to caregiver stress and burnout. Advocate for yourself in the healthcare system. Discuss palliative options with your doctor. And finally, not everything that affects your health is necessarily Parkinson's disease. So with that, I'd be happy to answer any questions that people would have.
Thank you, Martin, as always, very full of good information. I've already got a question. Do we have a microphone for, there is one down there, but I don't know.
I can give you this one.
And then you could use this mic? Let's do that.
Yeah.
All right. So this lady right there.
With regard to hallucinations and delusions, you say there are medicines that target it. Can you suggest what those might be?
Sure. So, as I said, the first thing is to rule out that there's nothing else going on. But assuming that's been done, there's two main medicines that we like for this. One is called quetiapine, or the trade name for it is Seroquel. And the reason why we like that one is the other medicines that are normally used for delusions and hallucinations worsen the Parkinsons. So that one does not worsen the Parkinsons. That's why we like that one. And then there's another one that's actually more effective, which is called clozapine. The reason why we don't use that one that often is it requires blood monitoring. You have to have your blood checked weekly for, I think, 6 months, and then it changes to bi-weekly. And that's because very, very rarely it can affect the blood count. But it is probably by far the most effective one for dealing with hallucinations and delusions.
Thank you, Dr. McKeown. My name is Sarb. I'm a social worker in Fraser Health, but I'm here today because my mom has Parkinson's, and she has advanced Parkinson's, more like brittle Parkinson's disease, as you described. And what my question is that so if she isn't a candidate for DBS because she does have like high anxiety, depression, there's a significant caregiver stress for my dad, and there's lots of other psychosocial stresses for them, and sometimes she's doing well, sometimes she's not doing well. If she isn't a candidate, but both for DBS and also for Duodopa, what are other options?
Well, this is a very challenging thing. As I said, first thing I would do is, the things that we mentioned that are a bit imperfect. We can take smaller doses more frequently. There is now a patch form, for example, for dopamine agonists, so you can put a patch on it and it gets absorbed at a steady state throughout the thing. So there are all these kind of little tricks that we do. And that may be imperfect. One thing I should say is I feel personally a little bit uncomfortable about discussing the risks of the DBS. I can quote you the literature, which is kind of across North America or across the world. But Dr. Honey, who does the operation, he would be the real expert to tell you what the risks are. And we have a low threshold for putting in a referral to Dr. Honey because he can always see you and say, in your case, I wouldn't recommend it. So, but there's no harm in seeing Dr. Honey except that his waiting list is excessively long, excessively long. So.
One of our advocacy issues that we're going to be dealing with this new government. If you're not an advocate yet, please contact me.
Hi,
Yes.
thank you, Dr. McKeown. Previously, I had heard about fatigue and whether or not sleeping 10 hours plus was, detrimental to increasing the symptoms. My husband naps twice a day, plus sleeps now through the night with the help of a new pill that Dr. Stossel gave him. Mm-hmm. And it has got me concerned that we should be looking at something else. And I just would like you to speak to that, if I should be concerned around the fact that he sleeps twice a day plus a full night.
Sleep is probably the next frontier where we don't understand it. Again, it's very hard for me to speak specifically on specific conditions, but if someone is excessively sleepy during the day, we do know that some of the medications, like the dopamine agonists, can make people excessively sleepy. We do know that people who may have sleep apnea, where they actually stop breathing in the middle of the night, so they never get the restful sleep. So even though they think they're getting 10 hours, the actual amount of restful sleep is very low, so they can be excessively sleepy during the day. And as I said, there may be other medications involved. So one of the things that I would say is a common culprit, and again, I don't want to pick on my cardiology colleagues, but I tell many of my patients that there's a difference between a cardiologist, what a cardiologist says is the best blood pressure, and what a neurologist says is the best blood pressure. From a cardiology point of view, from your heart's point of view, the best blood pressure is as low as possible. But sometimes it's so aggressive that their brain doesn't get enough blood and people are just fatigued all day. So, I say that what a neurologist will say is your blood pressure should be as low as possible, provided your brain is still happy. Now, I'm not saying that's happening in this case, but just to give you an idea that there may be a number of issues. But the things that the most common things that we would see would be medication-related, sleep apnea that's being undiagnosed, and there is a specialty sleep clinic, and there's in fact someone at UBC who is an expert in both sleep and Parkinson's, Dr. Valerio. And so he would be an expert to kind of look at this.
Any other questions? Is it usual to have the Parkinson medication half an hour before a meal?
How about what, sir?
Is it usual to have the medication half an hour before meal?
Yeah, so this is also something that causes a lot of confusion, and that is the relation of the timing of medicine with respect to meals. When people first start on the medicine, one of the things they notice is they get a bit of gut grief. In other words, their stomach gets a little bit upset. And so we often tell people to take the medicine with a little bit of food. And in fact, the levodopa gets absorbed past the stomach. So you often have to have it with a little bit of a snack, like a cookie or a cracker, just so it gets propelled past the stomach to get absorbed. Now, where the confusion arises is that it is known that when you take levodopa, it has to go from your stomach, then into the blood, and then from your blood into your brain. And it turns out that getting from the blood into the brain is a complicated matter, and it actually competes with protein. So what a lot of people will notice is if they have a high protein meal, that they will find that the levodopa does not work, or does not work as well. So that's why they often say take it, don't take it with protein. So there is a little anecdote, I think I can share this. So there was one gentleman who had advanced Parkinson's, and he was doing fine for many years, and then called and said, something's not right because, the medicines just aren't working. And we were scratching our heads. We couldn't figure out what it was. And then we finally discovered that the way he was taking the pills was with spoonfuls of peanut butter. And what was happening was that the protein in the peanut butter competed with the levodopa, and that's why it stopped working as well. So, I think it's reasonable to take it about a half hour or an hour on either side of the meals, just to avoid this kind of protein thing. As I said, early on in the disease, when the therapeutic window is very large, it doesn't really matter. And because early on in the disease, when people first start the medicine, they can get a bit of nausea. That's why we say take it with food. But with more advanced disease, people get used to the medicine, and then you have to be a little bit more cognizant of this, interaction with the protein.
In the middle there, Courtney.
Hello. I wonder if you could just comment on the relationship between gastroesophageal reflux, coughing at night, and resulting in pneumonia.
So yes, that's one thing that we often ask about. So one thing that the gastroesophageal reflux is, so in your stomach you have a lot of acid, and there's a little sphincter that's supposed to prevent acid from going from your stomach back up into your esophagus. And when that happens, that's called heartburn. So it's a bit of a misnomer that heartburn has nothing to do with your heart. It's to do with your esophagus. What happens with some people is when they lie down at night, some of the acid goes from their stomach up into the esophagus and then actually down into their lungs, and that can trigger coughing. So if we ever hear about people with that condition, we often put them on something called a PPI, a proton pump inhibitor, which is something that inhibits the ability of the stomach to produce acid. Just as an aside, there is a condition that's one of the Parkinson's plus conditions, which is Parkinsonism, but not Parkinson's disease, and specifically one called MSA. And we are very vigilant about that because sometimes what can happen is the acid can trigger the vocal cords to go into spasm, and that can affect your breathing. So we usually have a very low threshold about putting people on these acid blocking drugs. And if someone was coughing, we would definitely do that to prevent them from scarring their lungs.
Dr. McKeown, could you address the serotonin as a supplement to increase mood or up your mood?
Well, most of the antidepressants that are on the market are called SSRIs, which means that they actually work on the serotonin system. So they augment serotonin just like some medicines augment dopamine. So You're always taught that the problem with Parkinson's is not enough dopamine, but in fact, that's too simplistic. There are many other systems in the body that are affected, and one of them is the serotonin system. And so that's why we do see, that's probably the explanation of why the incidence of depression is so much higher in Parkinson's than other conditions. So that's why we often put people on medicines like venlafaxine or mirtazapine. These are drugs that are antidepressants that are sometimes used in psychiatry, but we use them for people with mood problems in Parkinson's. So. Yes, augment serotonin, that's correct, yeah.
No one mentions the freezing episodes. When they're frozen, you draw a line to step over or step on a foot or try to move, which weighs a ton. You can't move. Is there something you could give them, like a fast acting, that would make them move instead of being frozen?
Yes, that's an excellent question. So this is a very challenging problem, and there's many ways to address this. One is, so you're asking is, are there rescue therapies? There are a number that are being looked at, particularly in the States, but are not yet available. So some of them are an under-the-tongue preparation of levodopa. Another one's a spray, like a puffer, that could be used. There is a medication, apomorphine, that's an injectable form that's available in the States and not available in Canada. So there are these things that can be done. But one of the things that's interesting is we do some research with a group in Calgary where they have this technique where they're getting people to walk and listen to music. And one of the behavioral feature that improved the most was actually gait freezing. So just simple exercise may be one of the best things. And then there's other medications. When they did the study on rasagiline, they found that gait freezing seemed to improve. So sometimes if people have gait problems, we would consider adding that medication.
Other questions?
Just wait for the microphone.
I'm the original thank you, Charlie Chicken, or Chicken Charlie. I'm thinking of the deep penetration. Can you tell me the size of the pump, or what is it exactly that you cut open and stick in, and how long does it last?
Sorry, are you talking about the deep brain stimulation? The deep brain stimulation, it's a battery that goes under the skin, and it's about this big, and it goes under the skin, and then there's a wire that goes up under the skin and here that goes then deeper into the brain. Well, it depends on how much they turn up the current, which varies a lot from person to person, but the newer ones actually are rechargeable, which is kind of exciting. So, you can put this thing on your chest and it recharges it throughout the night, but usually sort of but usually it's about 5 to 10 years. But it's a much simpler operation to replace the battery because it's just under the skin, obviously, than placement of the electrode deep inside the brain, which is, requires a lot of skill, and that's why we're very fortunate to have Dr. Honey.
Okay. We can take still probably about 2 more questions way at the back of the room. I think there's 2 or 3.
I'm coming.
Coming for you. That's why we have young people to do it.
Not so young anymore. Where are we? Over here. Perfect. Sorry, excuse me.
I'm interested in the Duodopa pump.
Mm-hmm.
Is it permanently installed? And how much does that pump weigh?
Aha. What I may ask you is that you hand the microphone to the lady beside you.
Yeah, that's what I said, sitting beside the right lady. Yeah?
How much does the pump weigh?
I don't know the exact weight, but it's a few pounds.
Yeah, I thought it was 2.1 or something. So yes, it's detachable, and you typically don't wear it at night. But one of the things that they do in Toronto, which I think is quite clever, is they send people home with a pump in a pouch for 2 weeks. And they say, let us know, because some people come back and say, oh, that's not too bad. And other people come back and say, there's no way I can truck this thing around for 2 weeks, or, permanently. So that's often a very useful screen, so.
We have Ms. Olson up here, if any of you want to talk to her in the break. I'm sure she'd be happy to demonstrate. I would, yes.
Anybody else? Yeah, another one over here.
Does the pump interfere at all with physical activity or special kinds of physical activities like golf?
Now, whether or not it would put your swing off a little bit, that's a good question. But again, this kind of weighs back to what I was saying about weighing the risks and benefits. And sure, it is, we would only suggest it to people who are having a very difficult time with fluctuations during the day. So for those people, it can be a real game changer. But if you're doing well without the medications, it does not make sense to have, this pump that you're carrying around, so.
Any other questions? We still have a couple of minutes before we
Yeah.
need to break.
Okay.
This has been bugging me for a long time. I keep hearing that when patients go in the hospital with PD, that they probably won't get their meds on time if they're, from everything I've heard. Can the caregiver voice her concerns, or how does the staff respond to us saying, well, he needs his medication now, not an hour from now, or?
Yeah, so this is a very, very tough thing because, we can't completely restructure the whole healthcare system overnight. There are a couple of options that I think are available. One is, like for example, if someone's in a long-term care facility, I find that having a sit-down talk with the head nurse and say, listen, if they have if the nurses, who are often very overworked, if they have a list of 20 people that they have to give them medicines, maybe, my family member could be on the top of the list so that they get it first because it's time critical. The other option is, depending on who the attending physician is or the most responsible physician, they can write an order that says patient may take home medication. And that's very helpful. Now, obviously, they're a little bit concerned about that because you don't want people dosing in the hospital because then you don't know what they're taking. And usually, by definition, if they're in the hospital, they're quite ill. So you need to be knowing what people are taking. But, as I said, you could ask whether or not people could take their own medication. And very often, that's probably the best solution. And all the doctor would have to do is just say, patient may take home Parkinson's medicine. And